Okay, welcome everyone to our training event on the Nourish program, focused on addressing teen struggles with body image, mental health, and food. I'm Julie Tennille, Project Director for EPIC, and there is so much excitement about tonight's training. Let me just advance this slide. I'm so grateful to our presenting team, Laura Whitman and Natalie Loschiavo, and to our EPIC squad, Wendy Myers, our grant program coordinator, and Sarah Franciotti, our research assistant. Some important information about tonight's event. So first, please remain muted. Our presenters will be able to answer your questions following their presentation, and the Q&A is driven by your questions that you enter into the chat, and we'll have the Q&A starting around 7:40. Second, if you're just getting to the Zoom room, log in with your full name for attendance credit. If you need to change your name, click on the 3 dots in the upper right corner of your personal window. Finally, and please listen really closely, if you want CEUs or a certificate of attendance, you're required to attend the entire training. Complete the post-test survey and complete a certificate request form while the event is still live. The link will be available at the end of the post-test. Also, just a reminder that the goal of this research and training grant is to expand numbers of well-trained MSW, MED school counseling, and PsyD professionals working with children, adolescents, and transitional-aged youth in high need and high demand areas. Okay, so at this point, I'd like to introduce you to our trainers, Laura Whitman and Natalie Loschiavo. Please see a more detailed description of these practitioners on our EPIC website. We are so grateful to you and look forward to tonight's presentation. And I think that Natalie is going to be sharing her slides. So give us just a second for this transition.
Thank you. I think Laura is. So if there are any issues, it's Laura's fault.
That is 100% accurate.
In trouble, Laura.
Leave it to me. All right. So far, so good. Okay. Not working all right. Okay. So thank you, Julie, so much for that introduction. Natalie and I are really excited to be here with all of you, and thank you for all of you, so many of you tonight jumping in after maybe a long day of work or school. We are hoping that you find the conversation today helpful and educational, but again, really appreciated to have you here. As Julie said, we are going to be focusing tonight on the idea of integrated care, specifically within the field of adolescence and eating disorders. So really looking closely at the relationship between therapists and dietitians and how important it is, particularly in this population. So to get us started, we wanted to set the tone. And by doing so, we wanted to use this quote. So this is from Maslow, and it says, "If the only tool you have is a hammer, you tend to see every problem as a nail." So Maslow didn't know, but he was doing a really good job of promoting integrative care for us at the time. This idea of Maslow's hammer, this phenomena, has its roots in behavioral science, cognitive psychology, decision-making research. And what it shows and highlights is that if we rely too heavily on one perspective or one way of looking at something, we are going to have pitfalls or limitations into the work we can do. This has been persistent, and some of the things that continue to lead to this kind of narrowed view in treatment is things like expertise bias and siloed clinical care. It's through integrative care that we're really starting to see the value of working together, especially on our more complex cases and our complex disorders that we're working in within mental health. Research is showing us that in the particular field of eating disorders, when we work as an integrated team, the treatment outcomes of patients are far better, and they find a much better personal experience as well. So it is our hope, as well as a lot of people's, including the EPIC program, that integrative care will start to move beyond just the field of eating disorders, but in all aspects of mental health, nutrition care, and medicine. So tonight we hope to help you remember we want to look through a lot more tools, or use a lot more tools than just our hammers. Before we get started, we just wanted to share some research and quotes, or research and statistics around eating disorders and disordered eating. We'll take a minute to look at those. These stats are a lot to take in. It really shows how significant the issue of eating disorders and disordered eating is within our society for all populations. But when we're speaking specifically to our adolescents, we really need to be looking closely, because it is very much present, whether we're paying attention to it or not. So with that in mind, the objectives we have for tonight, we are really hoping to spend the majority of our time looking at case conceptualizations and really pointing out and looking at the differences between that integrated approach versus a more siloed clinical approach. We also are going to be able to share some video clips of a former client that we both worked with, who is going to speak to their own experience of treatment and different levels of care, and what it was like working with Natalie and I as a team, as well as their experiences working in not integrated treatment programs as well. But to get us started, we're going to spend a little time highlighting the role of nutrition care, which Natalie will get us into, and I will turn it over to her.
Thank you. Before I get started, I will echo what Laura said. It's really nice to be here, and Laura and I have worked together for a very, very long time. So it's always nice to be able to sit beside her, not necessarily figuratively, but and talk about these types of things. So yeah, kind of getting started, I did want to outline the role of a dietitian in healthcare in general, but specifically focusing tonight on mental health care and mental health care in adolescents. Historically, a dietitian really hasn't played a big role at all in the treatment of mental health in adolescents. We were much more dietary and much more kind of education around general nutrition in schools or in different community settings. We, historically would work in hospitals and under certain medical conditions, but the role of the dietitian was quite narrow for a long time. And that has shifted. And now we do have somewhat of a broader scope, and our expertise is being used in more areas, particularly in medicine. So a lot of times we are working out of primary care physicians' offices or in the outpatient setting, getting referrals from doctors and some other providers. Typically, though, we still are doing most of our work in the medical arena versus in the mental health arena, with the exception of eating disorders. So eating disorder care has now, for quite a few decades, integrated nutrition and integrated dietitians in the holistic treatment of eating disorders, and have really recognized the importance. There's a good amount of research behind that now that's well accepted. Insurance is now recognizing the importance of nutrition care, specifically with eating disorders. So that's where we've actually been able to pull a lot of our kind of information tonight and kind of extrapolate that to mental health on a larger scale versus just with eating disorders. We still have a long ways to go. We still have a long ways to go in the field of nutrition, and really also that extends into medicine in general, before we can really say that we as nutrition providers are being truly holistic and really considering all the factors that need to be considered from a psychological and social standpoint. So as I said, while we've made some great strides, the reality is that the vast majority of the nutrition research, education, and the recommendations that are mainstream and readily available were created for the same people that they were created by, which is wealthy, cisgendered white folks. And so as a result, as well as other probably factors, as a result, the nutrition recommendations that we have and the research that we have, and therefore the way that we practice, it does lack a lot of sensitivity and acknowledgement of different cultures, different socioeconomic statuses, religious considerations, physical abilities, mental health influences, and I mean, the list goes on and on. So we do have a lot of work to do in that area. And again, I do think the tides are slowly shifting, but we have a ways to go. I think it starts with conversations like this, and I think it starts with our integration with experts in those areas of social science and psychological science, so that we can really kind of better understand how to serve the population at large. So a little bit of a nod to the law of the hammer, and the title of our talk tonight is the importance of recognizing what can be missed if we are just looking at either nutrition or mental health. And so I wanted to kind of outline here the impact of nutrition on mood, and really kind of how remarkably the side effects of undernutrition or malnutrition or nutrient depletion actually mimics a lot of mood disorders and a lot of the things that we see that might land in your offices, right, as a mental health care provider. The other, I mean, you guys can read the slide. I don't need to read the slide to you, so you can read all of that and you can make those connections there and see the parallels. I think what's most important here to kind of recognize is that these side effects of nutrient depletion can happen even if someone appears well nourished. So I think that's an important point that as any professional or any clinician, treating clinician, recognize and acknowledge that a person can be malnourished and be at a high weight, or appear fairly well nourished, and that these side effects of nutrient depletion can actually happen within kind of several hours of not having enough nutrition. So this doesn't actually have to be prolonged malnutrition. We can see things like anxiety, fatigue, low energy, stress intolerance, mood instability, a lot of these things, cravings, even if we're talking, it's been 6, 7, 8 hours since the last meal. It doesn't have to be days and days or months on end. So I think that when we are looking at the whole patient, we're considering, if they're showing up with these symptoms, I think that it is important that we're looking at their diet, their nutrition, at least to a degree, to see if there's possibly an influence there that might need to be addressed by a nutrition professional. Similarly, when we're dealing with somebody for nutrition care, I think we cannot ignore the impacts that their mental health, of course, has on their ability to feed themselves. So, for example, a client might show up and is really having a hard time meeting the goals that we're setting. And as a clinician, we might continue to try to make those goals more and more achievable, say having dinner, putting together a dinner, and we may continue to simplify and simplify and simplify that dinner. And we find that they keep running into barriers. And without the kind of understanding of what might be happening from that for them from a mental health standpoint, we could really miss a lot of things and really kind of come to a point where we're no longer actually even able to serve the client, because we're ignoring this huge factor of, let's say, executive dysfunction or an ADHD that's getting in the way of them being able to really move through the food preparation process, or is causing them to feel paralyzed by the cleanup. So that's just one very kind of small example. But, there are others such as, some of the side effects of depression, low appetite, feelings of worthlessness. Maybe they don't feel deserving of the food that we're recommending that they eat. And without that consideration, we aren't going to be able to properly intervene and serve these clients. So before, I think, passing it back to Laura, I think this is a great quote that Laura actually found, that often is kind of used especially in eating disorder treatment. And we sort of talk about the fact that before we can even not me, I don't do it, before a therapist or a psychiatrist or psychologist can do their work and actually do the therapy to ultimately treat the eating disorder, the brain has to be fed. There are way too many things that malnutrition does to the brain that makes it impossible to actually do adequate therapy. And a malnourished brain also doesn't respond the same way to a lot of the pharmacological interventions as well. So we're not going to see the outcomes that we need with a malnourished brain. So specifically in eating disorders, first, the person has to be refed and nourished. And that can still happen with the support of therapy and psychiatry, but we kind of know that we're really not going to be able to do that really deep work that has to be done until we're working with a nourished brain. Because a malnourished brain is a brain that's constantly under threat. And so we also know what that means in terms of a person's ability to focus and their cognition, and ultimately they're kind of in this hyperarousal state all the time because of that constant state of threat. And this is a much more succinct way, this particular quote, of saying that compared to what I just did. So so I think that is
I think I just want to say before jumping into this slide that it is so important that we slow down and think about even our own experiences. There's nothing on those slides that's shocking, but I think there's so many times that we forget the impact and the experience we can all relate to of, sometimes going without, eating for a few hours, and the irritability you'll feel, the difficulty focusing, the walking around if we're trying to be more regulated and work on our emotions. If I haven't eaten, I can't do that. And I think also, as Natalie said, to be even able to begin to do our work, we have to have somebody in a place where they can access not just their survival brain, but their higher functioning brain. So the prefrontal cortex, which will not go online if a person is in survival mode. So to be able to think long-term versus short-term gains, to be able to think about, what I really want in my future, what do I want right now, about how it's impacting my relationships. This is the deeper work, as Natalie said. So much of early on treatment when we're dealing with eating disorders is very much at that surface level with them, because that's where you have to be. And then as we get refed, we're able to really kind of take it down into the layers of what eating disorders are really about and in what way they're serving a client. And so there's a lot of different components and I would say almost stages to doing this work. And it's so important that you're working hand in hand with each other throughout that as providers. So what I'm going to do is jump into particularly mental health as it comes to our adolescent population. And before we do that, what I want to acknowledge is I'm pretty sure that everybody who has joined this webinar has had the experience of their own adolescence. And so if we all slow down for a minute and think about what it was like in that period in your life. Some of us have to reflect a little bit farther back than others. But when we do, you probably are able to remember some experiences, some memories. They could be positive, they could be negative, they could be neutral. But I think most of us can relate to the idea that there was a lot going on, right? There's a lot happening, there's a lot to manage, and we're all trying to do that while balancing feeling cool and not having anybody notice us too much, but notice us enough. It's really challenging. And so when we think about our typical adolescence, we start to see that there's so much impacting them. There are so many different things that they're contending with, managing, trying to figure out how to work through, understand. And this is not even an exhausted list, right? There's a lot. There's a lot. And I think it's really important that those of us who are providers working with this population really take time to understand that so much of what's happening is in some ways norm, right? What's normal for a teenager in terms of what they're going through, and how do we separate that out from somebody who is also struggling with a mood disorder or trauma or an eating disorder, and see how all of those things kind of layer on top of each other. And that's a big part of the challenge sometimes, is trying to tease those things apart. When we talk about mental health in adolescence, you know, I've been a clinician for almost 20 years, and I would say without any hesitation that the acuity of mental health, particularly in the adolescent population, and this is in all levels of care during that time, has absolutely increased in not the right way, right? The trajectory has been poor. And that was the case a decade prior to COVID. And we were trying to figure out, why aren't things getting better when, you know, we know so much more and we understand so much more? Why are we still seeing adolescents struggle, and that struggle is increasing? We're still trying to understand that to some extent, but we do know some pieces, and they are listed there, or at least some of them are. I think it's really important to highlight some of them are out of our control, like the biology. We know that the age of puberty for adolescents is happening earlier and earlier, particularly for youth who identify or are born as female. And why this is important is not necessarily because we have to deal with that sooner, all the hormones and things like that, but these kids are experiencing things on an emotional and social level that their brains have not caught up yet to be able to handle. The complex feelings, the difficulty in the relationships and the circumstances, they don't yet have the cognitive functioning to really address and do these things well. You know, so in some ways it's very much the cart before the horse. And so we're asking these kids to manage all this, some of which, when I look at the previous slide, kind of overwhelms me. And we're asking these kids to do this when they're really not yet at a point where they have the skills to do so or the tools to do so. So that's a factor. Structural factors, these are things that we know to be true and have been true and continue to be major impacts on all of our well-being, right? But particularly in our development as children and adolescents. And we can't ignore how much they continue to impact mental health, both at that time period and throughout a person's life. And then finally, another piece that is not a part of, I know, my experience growing up, and potentially a lot of ours, the impact of social media. We are still trying to figure out and really understand it, but we do know there are some great aspects and there are important things that it gives us. And then we can also see some real detrimental pieces. And I don't have to get into that. By no means do I want to bash social media, but I think one of the most important things to think about when we look at it from this angle is really the exposure. you know, as an adolescent now, you are being flooded constantly with images, messaging about things you should be, what you should look like, how you should act, and you can't get away from it. And that constant flooding really makes it hard to be able to sift through what is normal, so to speak, quote unquote. What should I expect of myself at this age? Whether it's about my body, about my, you know, ability to manage things, be in relationships, whatever that looks like, um, compared to what I'm seeing in front of me. Because what it looks like is that these are things I should be able to do, when really there's a lot of very unrealistic standards being set up for people. So I think that piece alone causes us to have to really sit down and help kids understand that part of it, or at least be willing to look at it. We can't talk about mental health for anybody right now without also acknowledging COVID-19. Everyone, 100% was impacted by this in different ways. We know in some ways our adolescents really were challenged. And I think if you are somebody that works with adolescents, if you have a person in your life, we see this. We already are seeing some of the ways that, you know, socially, emotionally, our kids were impacted by this. As I work with adolescents right now, we can really see there's a little bit of a gap that these kids, because they were pulled out of those everyday experiences of interacting with peers, being in a school setting, having to go and do these things, that they're still catching up in some ways. And without needing to go through all of these, an aspect that I do think is important to point out as well that we don't always think about is when it talks about academic disruption, of course, education and learning was impacted for a lot of people. But when kids stopped going to school, the actual physical building, they also lost resources. And that might have been being able to go to the school counselor or social worker. That might have been a favorite teacher that just made them feel, you know, supported and good. It could have been access to school lunches and free meals and things like that. So many things that are protective factors in regards to mental health were kind of cut off or really disrupted for kids. And that had a huge impact in and of itself. Another thing to highlight is we know that particular populations of adolescents were impacted at a greater level than others, and that's not surprising. The last point, our LGBT plus population, female identified youth, and any youth who experienced racism. That's not a small group, but these were the populations and the identities that felt the impact of the pandemic in a greater way and saw it play out more so in their mental health. So thinking of all the complexity that goes into working with adolescents in just regular development, we then are looking at, we're going to add an eating disorder, which is one of the more complex disorders that we can work with because there are so many different factors that play into it. And one, we don't have control of a lot of them. And also we don't fully always understand how all these pieces come together. And we can't therefore totally prevent it or, you know, mitigate it in a lot of ways. So if you look at the development, there are so many things happening at once that lead to kind of this perfect storm for some people. And what it looks like and how it interacts is going to be different for every single person. You may have two people with the same diagnosis, but how it presents and what it looks like in that person's life is going to happen very differently. And eating disorders aren't just complex in how they develop, they're extremely complex in the way they impact a person's life. And I think it's in this area more than anything that we really see the need for the integrated care. Because as we talked about earlier, I can't even touch, you know, working with somebody on a psychological or social level if I don't have a person who's able to receive that information in therapy and work with me. So if they are not medically stable, if they are not nourished to be able to start doing that work, there's nothing I can do, right? And there has never been a situation, and I'm pretty sure Natalie will agree with me on this, that I've worked with a client who just has an eating disorder. That's not how eating disorders work. What we know is they're typically a coping strategy for other things, and then they kind of take on also a life of their own. So the comorbid pathology is really key here because we might be kind of seeing a layering of multiple things happening. mood disorders, trauma, substance abuse, and that's all on top of everything we discussed for adolescents, while we're also trying to work with and manage the eating disorder. So the need to not get siloed in how we look at a case and not kind of open our view to all of these things happening at once is so key and so vital. And that, I think, is probably the biggest reason we have to really approach this from this integrated way. Getting into a little bit about mental health in eating disorders, we talked a little historically about nutrition. One of the things that we have to be willing to look at when we're talking about the history of treating eating disorders is also why, when we treat eating disorders, we are never proactive. Unfortunately, in mental health, we do a good job in some areas of trying to proactively create awareness. I think anxiety, depression, the impacts of bullying, even suicide. I think we have, as a society, done a lot better, and us as professionals have done a lot better to say, hey, we don't need to wait until this is a major issue. Let's get ahead of this. Let's try to help people, and especially kids and adolescents. Within eating disorder treatment, that has not happened. We don't respond until a person is in crisis. We don't treat until we're really at the point of somebody needing to be hospitalized or they need a higher level of care. And if we really slow down and think about why that is, it's a little disheartening. And for those of us who are in the field, you could get us up talking about this for hours and hours. But a lot of it has to do with the fact that if we're really going to address and proactively look at eating disorders and disordered eating, it means we have to be willing to take a very hard look at our society as a whole and the norms that we have set, because they are disordered and they create an environment where these things go and they're normalized and they're ignored, they're even cheered. And until a person is in crisis, we don't see an issue. And so that's a big part of when we talk about working with eating disorders, we're battling not just the disorder itself, but the norms that are created around somebody functioning in these ways. And we're going to talk a little bit more about that in some of our next slides.
Actually, and before I do that, actually, Jason mentioned something in the chat, and I very much appreciate you sharing that, because not only is it important, but it was a reminder that that is something that I wanted to say previously, but it fits here as well, which is when we are considering malnutrition, undernutrition, we do need to look outside of even just the lens of eating disorders or disordered eating, which I'm going to kind of talk a little bit about that spectrum, but also food insecurity, and or other conditions or situations that might be contributing to poor nutrition. And so I think that I appreciate you bringing that up, and I think that's a good point, because it's not just the malnutrition that arises from eating disorders that can cause all of that other cascade of issues that we kind of talked about that are very related to mental health. And certainly also there's the medical complications. There are a lot of other conditions as well that can put adolescents at risk of malnutrition and create very, very significant problems across the kind of health spectrum.
Just to add, Jason shared another piece, and I would love to address that more a little bit in the question and answer about addressing and how do we support, even outside of the realm of eating disorders, kids who are in socioeconomic status where they are malnourished or different situations. And that is something I think we will speak to in challenging some of the norms, also in the work we do as professionals, making people aware of the need to continue to address those structural factors that we talked about, right? Poverty, food insecurity, all the unfortunate discriminations that happen that lead people into those settings, but we can definitely speak to that as well at the end. So I really appreciate that point you made.
Yeah. Well, and to respond to a couple other comments, and then we'll kind of get back to this, but I think this is so important, so I really do want to speak to it. I think it really speaks to the importance of the integrative care too, right? Because there are lots of services out there that can be utilized. You have to dig for them. You have to find them. And that's best done with a team of professionals doing it. Utilizing, for example, what dietitians are trained in terms of community health or community nutrition, because there is a lot of training that we receive around that, and a lot of resources that we have kind of in our database that can serve certain populations. And so, and again, similar to mental health professionals, and a lot of it might overlap, but there may be some things that we can learn from one another and resources that we can share. So I think that that is a really important point and very, very relevant to this conversation, because I think that various different disciplines do have different resources that can help to possibly serve these individuals. So coming together and putting those resources together is critical. In regards to kind of what Laura was talking about just a moment ago, is this idea of kind of the spectrum of disordered eating. So we have your eating disorders that are, meet diagnostic criteria for eating disorders. And luckily that diagnostic criteria has been broadened over the past several years. Well, we're due for an upgrade, but it's gotten broader, which is great. However, it still doesn't encompass everything that is disordered eating and dysfunctional eating. It does run quite the spectrum. And I think, unfortunately, as Laura mentioned, because of the influence of the media and some of our biases and kind of fear of fatness, that a lot of the disordered eating or dysfunctional eating is glorified or minimized at the very least, because it kind of hides under this guise of health and trying to control weight for purposes of health. So I think it is important to recognize that, I mean, so many of the clients that walk into my office, truthfully, their eating disorder started with, especially adolescents, their eating disorder started with trying to get healthy. It started with really good intentions, but unfortunately, not enough information or education and too much social influence and not enough influence from providers who know what they're doing. And it very quickly went from a desire to be healthy to getting to a point of being very, very sick. And so I now am always very tuned in when anyone tells me that they're changing their diet to be healthy, particularly an adolescent or a child, because there's so much risk there. There's so much risk that it kind of goes to the far end of the spectrum and goes right into eating disorders, or it stays in this eating disorder or this disordered place for a long time, which ultimately leads to just kind of a lifelong journey of kind of yo-yo dieting, which most people don't enjoy, and does impact mental and physical health pretty significantly.
I just some great comments in the chat as well. Casey talking about we're drowning in sizeism and fat phobia and diet culture's out of control. I'm interested in seeing how the use of Ozempic plays out in this over time. To those of us who really are into social justice, this may or may not be the population of people to be speaking to. But one of the most fascinating things is to look at the intersection of our cultural focus on body and eating and how it overlaps with racism, how it overlaps with all of the isms that we battle and face. And as Natalie said, it is so intertwined and it is so rooted that people don't even really notice it. And I would say one of the ways you can see that is the hope, you want to believe is that if you are out in the world, somebody says something that's, say, as a member of the LGBT community, if I hear somebody, I feel like more times than not, somebody might try to correct somebody if they're being outwardly discriminatory, my hope. When you are out in the world, you will hear people speak to and discriminate against people of size, and they think they're doing that person a service. And they think they have a right to speak to that person in that way. And I think it is one of the things that is so blatantly missed is how discriminatory, how intense, and how overwhelming weight stigma impacts our society, and not just for those who have are in larger bodies, but for the people who exist in that society who are constantly in a place of feeling like they have to other people who are, because if they become that, then they become subject to that same discrimination and fear. And it is a really scary and dangerous place for us to operate. And at the end, we can share some incredible resources if you are interested in reading more about those intersections. That is, I love to read those kinds of things. So I have some great resources for you all later.
This is just fascinating to me. That a adolescent's brain is developing developing at the same rate basically as a toddler. Maybe because I currently have a toddler, so that just blows my mind that that could ever happen again in life, that a brain could develop like that again. But it does, and this speaks to the importance of nutrition, obviously across the ages. But as it states here, we would never try to limit, I hope, a toddler's intake, because we do understand the impact of that. Whereas, unfortunately, we're doing that a lot in adolescence.
And encouraging, right? We see, because again, we see the concern and the fear of maybe if we're speaking to parents, their child growing up and having to deal with the potential discrimination or impact of their body not meeting society standards. They'll encourage and think again, they're doing something that's in their child's best interest. And this is where education comes in. This is where really breaking down these stereotypes and these distorted beliefs about what health and wellness actually is. And that's where a lot of our work is in these conversations, and also work with the families, because there's a lot that unfortunately we're all indoctrinated in it, and we have to be willing to slow down and think about our own experience and what we take in and what we, whether conscious or not, are promoting. Okay, so before we switch gears a little bit, we decided that potentially the best way to kind of speak to integrative care was to use some case conceptualizations. So Natalie and I spent some time and we created some focused purely through our own lenses. So mine will be purely clinical. Natalie's is purely through that of a dietitian. What we're going to do is we are going to show these to you. We're going to, instead of having us read them directly to you, we're going to leave them up on screen, highlight a few things after you've had a chance to read, and then we'll talk a little bit about them. Okay. So the first is going to be my conceptualization of a case. I'm going to give you some time to take your time to read this. This continues on the next page, but to just highlight some of the key things that we can pull out is we have a 16-year-old white non-binary client who's being referred by a school counselor for a number of concerning behaviors, including suicidal ideation, self-harm, school avoidance. Recently had been sent to crisis for an evaluation for making comments like wanting to die. Upon sitting down with this client for your first session, you learn that they live with their mom and their younger sibling lives with their dad. Parents have a very contentious relationship, and mom is actively in an addiction of alcoholism, and in the past has been physically, emotionally, and verbally abusive. CPS has been reported. And the kid shares with us that while there is no longer physical abuse, there continues to be emotional and verbal. So this is a continuation. And again, to just highlight a few specifics on this page, we learned that the majority of these symptoms have presented since the age of 10. We also know that the client has what they describe as mood swings. They are impulsive in their behaviors. They use substances. Definitely some strengths that we can see and recognize for this kid. And also we see some concerns outside of the presenting symptoms, including the lack of parent involvement, as well as the kid wanting to, not have their parent be a part of it. So I want you to imagine for a second that you are an outpatient therapist and this kid walks into your office. What do you think? Where do you focus? And while you are creating your treatment plan and your goals, we're going to shift to Natalie's conceptualization of a case.
Okay, so I will let you read or skim some of this as well. So 16-year-old youth identifies as non-binary using they, them pronouns. Patient sex assigned at birth is female. Arrives at dietitian's office for nutrition services after referral from school counselor for concerns around skipping some meals at school and reports of restriction overall, as well as some recent self-induced vomiting. Patient was very pleasant. The patient's mother dropped them off at the appointment, but did not stay for the duration of the appointment. Patient reports a 10-pound weight loss over the past 3 months. Growth charts aren't available for review, but typically that's not normal in this age population. Patient's history with weight: patient attended Weight Watchers meetings with their mother from age 10 to 12. Prior to fairly recently, over the past few years, patient reports no significant body image distress. However, that that fairly recently changed after their doctor advised them to start eating healthier and exercising, and cautioned them about getting fat.
Ready for a shift?
Yeah. So patient's report does align with the counselor's concern that there is restriction happening. Patient states that they try to go as long as possible without eating during the day. So they'll eat as little as they can throughout the day. And then oftentimes when getting home after school, they report extreme hunger that sometimes they're able to suppress with drinking a lot of water, et cetera, but oftentimes they have larger portions in the evening, after dinner, or after school. And over the past couple of months have started to engage in purging behaviors through self-induced vomiting. You can see the frequency here. Restriction was reported to have started about 3 months ago, and purging behaviors about 2 months ago, and currently the frequency is about 2 times a week. Patient does report poor body image and did provide the RD with a weight goal of 110 pounds.
So same kind of thinking about this case from where would you go? How would you begin to address?
Mm-hmm.
Did I just go to the same one? No. Did I jump ahead? Yes.
Okay, this is just, so that's all right. Just the kind of impression overall was just that the patient is at high risk of malnutrition and eating disorders. The details are there for your review, but ultimately the nutrition interventions are going to be eliminating purging behaviors and ultimately connecting with therapist and anybody else who is part of the care team or potential care team to kind of gather some more information.
Okay. So not sure if you guessed our twist, but this is the same client. And just so you also know, it was really hard for us to do this. We actually found this exercise very challenging because it is very different and hard for us to not use an integrative lens. But if you did guess our twist, or even if you didn't, I don't think it's hard to see how different these presentations look, and that if you didn't know what we were talking about this evening, you would look at these and probably see, yeah, there's some similarities, but you might easily think these are 2 very different clients. And so what we wanted to do is now come back and look at both of these and see if we do look through an integrated lens, how do we put together a much more thorough and clearer picture using all the puzzles that we have. So to start us off, we both are getting the referral from the school counselor, which is wonderful. One thing we can't rely on is the school counselor going to have an integrative approach to care, meaning they call Natalie and are they thinking, hey, it'll really help Natalie have the bigger context of what's going on for this kid? And when they call me, did they think it matters at all to share with me that they're struggling with food or body? And is that just something that they think they should be talking to Natalie about? Natalie, do you want to say anything to that?
No, I think that covers it.
So again, we have to be thinking for ourselves about this lens. Are we asking certain questions? Are we, as Natalie did a nice job saying, are we identifying who else is in this treatment team to make sure that we're not missing any pieces of the puzzle and relying on the fact that we need to be the ones actively seeking that out? I'll let you start with this section.
Okay, so symptoms consistent with anorexia nervosa with purging behaviors. I think that a lot of the things to kind of consider there that I think would be, you know, that I would want clarity on from the therapist and want some input on from the therapist would be something like trauma history or other behaviors that, similar to purging, can be somewhat impulsive and kind of what's showing up there, because a lot of times, like I said, we see some kind of parallel behaviors, particularly with purging behaviors, but certainly also with restrictive behaviors as well. And in this particular case, again, trauma history, self-injurious behavior, substance use, a lot of things that very much, like I said, we often do see with purging behaviors. a quick question. I'm sorry. SIV, self-induced vomiting. So a patient reports a 10-pound weight loss over the past 3 months. I think in that, it's important to kind of consider what all factors could be contributing to that as well. So, you know, while it could be just that the patient is not eating because they are wanting to lose weight, which might be what it looks like kind of on the surface, if I'm just looking just kind of from the surface, it could also be related to mood instability. It could be related to depression or anxiety. It could be related to food insecurity, or potentially food is available, but the age of this child is such that if mom's not able and is not making meals at home or providing meals at home in any way, that could be contributing to an insufficient intake and weight loss. Laura, did you want to pop in? I'm trying to think where else what
Yeah,
other considerations there are.
I love kind of pointing out one of the things that I think is so important is in our ability to assess a client, asking direct questions and really being able to do that as clinicians is how we are going to get, you know, a much broader understanding of what's going on for this client. And if we're talking about a kid that is, let's say, in our case, conceptualization, first off, every client, no matter who we're working with, has a relationship with food and a relationship with a body, because everyone does. And so even if I'm not working specifically within the field of eating disorders, those should be conversations I'm having. And I should be thinking about also certain populations may show a higher risk factor, and that I should be kind of cued into. And I think this case shows us that on a couple different places. One, an adolescent, right? This is an age we know where they're really kind of, you know, at risk for this, and also just really having a lot of changes happen and a lot of influence, like we talked about. Another major identity that is at a high risk is our trans community. Any LGBT plus adolescent is at a high risk, but our trans community and non-binary folk are significantly higher. And this is really important that we be able to kind of walk this line of talking about the differences between body image and gender dysphoria and how they overlap and how they're very different, and not make assumptions about what a person is experiencing. So if we're working with this population and we hear somebody talking in a way about their body, we might just, hey, that's just gender dysphoria. That's pretty typical. We have to be able to kind of tease that out and consider that there might also be other behaviors. It could be a part of it. It could be, you know, helping, or it could be related to it. It may not be. And that's been the case a lot with clients that I've worked with. They really can separate those two out. So who are we working with, and are we asking the direct questions? I think one thing that we also know, especially in adolescents, is they're not always the best historians, right? They're not always going to give us a clear picture. Sometimes that's because, going back to what we talked about earlier, they may not recognize their behaviors related to food or disordered eating as a problem. It may be something that even if they know it's probably not the best, they're not willing or wanting to change it. So why am I going to talk about it with you? And some of what we'll talk about, and I think is so important for us to talk and focus on, and we'll do so later, is understanding that any behavior, even behaviors such as purging and self-harm and all the different things we're talking about, has a purpose. It's serving our clients in some way. And we have to be willing to look at what that is and help the client understand that, because these are all attempts to cope and survive. And if we can better understand that, then we really can work with the client to help them identify if there are other things that they can turn to and use. And we'll get much more into that. But again, speaking to kind of the overlap, if I don't know that this client is working with a dietitian and Natalie and I aren't directly supporting each other in this case, I don't know that this is a kid who potentially is at a medical risk because of the recent weight loss, and there's concern in regards to, you know, they need to get some vitals and labs done. I'm worrying about potentially a lot of stuff over here regarding safety, but I might be missing the most immediate risk to this client, which is their medical stability. So working together to say, hey, you got to get to the doctor, or helping them get there if there are resource issues or financial issues that get in the way, helping them find clinics, helping them find ways that I can support them in getting those things done. And also, like Natalie said, when we kind of overlap all of this, it makes a lot of sense that we would see this presentation from a client, because when somebody has experienced trauma, which also puts them at a greater risk for an eating disorder, or they're actively also engaging in substances, which also is a comorbidity of eating disorders. When somebody has, challenges in mood stability, all of these are very common. But when somebody has limited control in their life, when there's a lot of factors that are happening that they have no chance of being able to really impact, which, if we think about it, is a lot for adolescents, it is not so far-fetched to think that, conscious or unconscious, I'm going to look for ways to control things. And it may be very few things that I can do that with. Food and my body are things that we can kind of go to and think that this is going to help us manage all these other things. So we can see by knowing and talking to each other how this all kind of comes together and makes sense. Whereas separately, we're working on two very different agendas. Go ahead.
Well, and I think at this point, we've I hope, demonstrated the complexity of an eating disorder and the very different kind of roles and information that a therapist might gain and a dietitian might gain, and trying to kind of triage what is kind of most important and what needs to be addressed first is a very, very, very difficult task. And so I think part of the collaboration is really putting our brains together and doing our best to do that, to kind of say, okay, what is the most important thing that we are looking at first and addressing first in order to keep this client safe, and really kind of supporting each other clinically in that, because sometimes there isn't a clear answer on that. And so the more professionals who understand and the more perspectives that we have, the better our chances are of tackling kind of the most important thing first, and then so on and so forth. And I saw a bunch of kind of questions pop up about DEXA scan, and it looks like those questions were answered, which is wonderful, but also kind of demonstrating the importance of collaborative care and integrative care. Because if a dietitian is giving a recommendation to a patient, and then is bringing any concerns or anxieties or anything like that to the therapist, which happens often. A dietitian might make a meal plan recommendation. They might recommend certain labs or certain medical testing. Go see your primary care physician. And that communication is really important, because usually we're educating each other too when we're working in an integrative way. I'm kind of helping the therapist to really kind of understand my recommendations, what they are, what abbreviations mean, and vice versa. And so part of that integrative care is to answer those questions. And there's so many times where I'm collaborating with Laura and I'm like, hold up, you just said a word that I don't know. Help me understand that as well. So that actually brings up a really important point that is very much part of integrative care, because we can't really work in an integrative way unless we are teaching each other about our disciplines and about our areas of specialty.
And what's great about that is I can't know everything, right? We can't be experts in everything, nor should we try to be. But what ends up happening is there ends up being, I think, a helpful little bit of overlap where a client's going to come into me and they start talking about, can you believe Natalie's telling me I have to do this meal plan with this, or they're telling me I have to do this. I may be able to kind of like understand like 3 words out of that sentence, but what I know, because we've been collaborating, is yeah, I can, and here's why, and yeah, we talked about it. It does make sense to me, and it prevents splitting. It prevents, the client walking in, not because they're trying to get away with anything, but because they're really struggling. And if we're working together and they're getting that same message from both of us, and we can both say, hey, look, I can't explain how Natalie came up with this meal plan for you, but I bet you if you want to go and talk to her more specifically and ask her, she can do that for you. Why don't we do that? So you feel like you can understand where she's getting that from. And there's a lot of times when one of the best things that I'm able to do is say, that is an awesome question. We need to ask Natalie that. And that is amazing to know that I can go and have that conversation. And I know my client is going to be able to get that answer, and vice versa. I can't tell you how many times I'm like, tag Natalie's it. And likewise, we do that for each other. And that's really helpful for the client to see as well.
Mm.
I know there's a lot of things in the chat. I think as we go through this next section, it will answer some things as well, but my hope is also too, I really hope people bring some of these questions into the chat at the end, because there's a lot we want to be able to respond to and share as well. Okay. All right. So this section of the presentation, I think, is one we are most excited about, and where we felt that we were really going to be able to share with all of you the kind of lived experience, so to speak, both as providers, but really most importantly, as always, from the client's perspective. Natalie and I over the years have had the opportunity to share a number of clients together, and we reached out to one that is a former client of mine and Natalie still works with, and asked them if they would be open to having a conversation with us about the presentation and the idea of integrative care and what it was like to work with the two of us. And they were very gracious and open to doing that, and sat with us over Zoom, and we had a wonderful call for about an hour and a half. And we are going to use some clips from that and share with you some of the insight that our client Blaze had to share, and we'll kind of talk through and highlight some things as well. Anything before we jump into this, Natalie?
No, I don't think so. I don't think so. Let's introduce Blaze, or let them introduce themselves. Oh,
That's not Blaze. This is Blaze.
My name is Blaze. I use they, them pronouns. I live in Harrisburg, Pennsylvania with my dog and my partner of almost 3 years. My journey started off very young with like the mental health world. I began therapy probably at the age of 7 or 8 for OCD behaviors, and also a little bit of purging at the time, but it wasn't really thought of anything significant until later on. But I had been in and out of therapy since I was 7 or 8.
So to give you a little bit of background, I think Blaze mentions a little bit later that I worked with Blaze for almost a decade, which means Natalie's worked with Blaze for longer than that. And when we first began working with them, they were an adolescent. I want to say 15, maybe 16. So it was a long-term kind of case that we both were able to share. Please enjoy these paused views of us during these video and the captions. We found this extremely entertaining for ourselves, and so I hope you enjoy them as well. So this clip is about siloed treatment providers and what Blaze experienced when they had that in their treatment.
You know, teams sometimes that don't have all those pieces that you need. When that's been your experience, so the opposite, I guess, of the integrative, what about that maybe didn't work for you? And maybe what did? I don't know, just a little bit to that.
Yeah, I mean, one thing I definitely think of is when I've had teams not working well together, feel really unheard and kind of like pushed to the side. And, you know, that brings up even bigger feelings of feeling like unimportant or just worthless. And then I spiral. But like, it also just like really makes me mad, because like, I hate when there's a lack of communication, and that's usually what it is. Like, there's just a lack of or no communication. It's really hard for me. And then in the past, what I have done is kind of been resentful, and I'm trying to think of like the phrase for it, but I I act out basically. And that way, then I get attention because I want someone to pay attention to me. And, you know, sometimes it worked, but I didn't get the attention that I wanted, you know, like I wanted to be acknowledged and like cared for in that, you know, in that type of way. But instead I was being reprimanded.
Natalie, you want to respond first?
Yeah, I mean, I think this, I think this kind of one of the most important things that they say here is just their kind of reaction to it, which I think, of course, is the most important thing. And their reaction is kind of what you would expect an adolescent to do if they weren't feeling heard, or if they felt like their providers or caregivers aren't on the same page or sending the same message, or that they really care, which is act out, amplify in order to be cared for, especially if that's what they know, right? Especially if that's how they've ever, the only way they've ever received that type of, any type of attention or care. And so, you know, that to me that really stuck out to me when we were talking to them, Laura, is their very clear way of kind of articulating that. And something that I hadn't really fully considered. So I wasn't exactly expecting that. I was expecting the not feeling heard, which is so important, not feeling important or worthy, because again, those are already core beliefs. But also just how they then tried to get that, right? And how it ultimately played out with providers who weren't communicating well or weren't kind of practicing this integrative model of care.
Yeah, and I think, you know, if we slow it down and think about it, basically Blaze is setting up for us that it is the providers not providing adequate care that then leads to these behaviors that then the client is getting reprimanded for, and their trauma narratives are being reinforced. So instead of providing and supporting and helping our clients kind of work through these experiences, we're actually reinforcing them. And then unfortunately, you know, what can happen is, you know, in our field, I think it's really important as clinicians and as providers of all kinds that we stop and reflect at when somebody is acting out, as Blaze says they were, or resisting, or, you know, they're not kind of following treatment plans. Sometimes we'll hear language from people about this is a treatment resistant client, or this person isn't motivated and they're not trying. That to me is something that as professionals, we really have to move away from. And I think we do that when we're tired, when we're maybe stressed, and also when we're feeling frustrated. But when we slow down and really step back, I think what we can see and ask ourselves is, what is being communicated to us here? I will go back to my graduate school days. I was MED at Master of Education at Westchester. And one of the most profound things one of my practicum advisors said to me was, every behavior is done because it works in some way. Even the ones that don't make any sense to you or even the person doing them. You have to find the purpose it serves. And every time as a clinician, I'm stuck in a situation where like, I don't get it. Why is this person doing this or whatever? If I can remember to slow down and really try to help me understand that, and sometimes help the client understand it, it creates so much more opportunity to support and help them move through than to just shut the door and say they're just not trying. You know, they're just not, they're just resistant. And be willing to look at, is there things that I'm doing that's potentially contributing to them not feeling validated, seen, or their needs aren't getting met? And that's not always easy to do as a provider, to look at ourselves in that way. And I think that again is where being a part of a team is so helpful, because we have people to bounce off of, and people who know the case, and people who understand it and may be feeling similarly, but also may be able to kind of stay more grounded than maybe I can in a moment, or vice versa. I think, especially with Blaze, there were a lot of times in treatment that were really challenging, frustrating, scary, I know for me, and it was being able to talk to Natalie and sometimes vent, but also then kind of come back and say, okay, what do we need to do here? That really allowed us, I think, hopefully, to be that consistent and supportive team for Blaze, and that they didn't feel overlooked or unheard. I'm ready to jump. This is my favorite. So again, kind of talking about from the adolescence experience. Again, very different than somebody who is an adult seeking services. We work with families all the time and obviously need to. It's an important piece, but it's really important to hear what Blaze has to say about that.
Validated and seen.
Yeah, because I mean, also like when I've been in situations before with providers, whether joined as a team or just like individuals, but they'll be talking to my parents or at me, not really to me. And I'm kind of sitting in a chair in the corner, just kind of hearing it all happen. And like, I feel like I'm being like tossed around and like, they're like, well, they're going to do this next and then this and this and this and this. And then I'm just like, but what about what I think, you know, but no one, at least for me, and I really hope it's different in those treatment centers and, you know, universally now, but like, I hope that's different, that kids and teenagers are more heard.
Yeah.
You know, I think, again, it's so important with whomever we're working with that they feel validated and seen. And while a lot of adolescents need their parents to also be a part of this process, I think particularly it's really important that we allow kids to have their voice, their say. It doesn't always mean everything's gonna go the way they exactly want it to. And that's something we talked about some of these other clips, but that they have that opportunity to feel that they are a part of it and helping make these decisions is both validating and I think empowering. And that's something we really want to help, especially adolescents and young kids, but all clients feel is empowered to help themselves and to utilize resources that are there for them. You good, Natalie?
Yeah, let's keep going.
All right. Apparently I just want to stay on this beautiful clip. This is good. Okay. So the experience of working with an integrated team versus a siloed team.
A lot of times therapists, at least in my experience, therapists and dietitian are working really, really closely together in eating disorders and can sometimes take on kind of primary support roles for clients who don't have that at home, especially when we're talking adolescents, young adults. And you kind of mentioned that, Blaze, basically that like you didn't have support outside of your treatment team.
Yeah.
Can you describe what that's like? Like actually, I don't even want to lead you any further. Can you describe what that's like?
You know, the first thing I'll say is that you both were not my first like team put together. I had a dietitian and a therapist before I went to treatment for the first time. They did not work together at all. They were not good fits for me. Like it was a mess. I complained the whole way about it, as I do, but like it was just so bad. And then I met you guys, and generally, like things were pretty good. Like you guys worked very well together, and I really appreciated that. It was very helpful having, like, I'll just use you guys for like, because you made that example, but like two people that are on the same page about me and my well-being and like actually gave a shit, because like my last team only cared about numbers. They cared about like money, and like, you know, they didn't really care about me as a person, and they only saw me as an eating disorder. So when I met you guys, it was kind of like a breath of fresh air, because you were more knowledgeable. You actually gave a shit. And it was hard because at times it felt really, really nice because, like, I mean, I still work with you, Natalie, and Laura, I worked with you for almost 10 years. Like, we worked together for a very long time, you know, so that was nice, you know, being with you guys and working with you guys. But it was really hard having a team that's supportive sometimes too, because like I said a few minutes ago, I still had to go home, you know? And so since I didn't get that support at home, it was really hard. But like I'll be honest, like I would look forward to like my Saturday appointments with Laura at noon, like every week in Philly, because I knew I would have a space where I felt safe and comfortable. And like in that hour, it would be hard as hell probably because I'm talking about really difficult things, but I'd feel safe, you know, and same with Natalie. So yeah, it's great having a team that supports you and believes in you and will do anything for you probably, but it's also really hard when you don't come from any of that from anywhere else, you know?
This, I think I always need this kind of reminder, because I think that I've learned through years and years of doing this how important it is to provide a safe space, and how much clients appreciate and oftentimes need that. And the thing that I often have to remind myself is what happens when they leave my office. And that while it can feel nice being in a safe space, when you have to go back to something that's so unsafe, there can be so many complicated emotions that come up just from that. And not to mention the fact that while it might feel nice that your dietitian or your therapist feel so incredibly safe, how also hard and sad that may make someone feel when that's their reality, that's their safe space, because it's not supposed to be. You know, that's not supposed to be where they go to feel safe. And so I think here Blaze really illustrated that. And I think, again, kind of speaking to the integrative model, especially as a dietitian, those aren't the things that I'm taught in school. I'm not taught how to make create a safe space for my patients. And I learned that both from my patients, of course, and we'll kind of talk about how they're part of this integrative model, or we'll speak to that later. But I learned that from collaborating with therapists and other professionals, who were able to give me that perspective, so that when I am sitting with a client and we have a wonderful session and they seem to be feeling really good and very connected and very cared for, that when they leave, there are going to be kind of some, not consequences, but sort of, right? So I think it was wonderful that and so honest that Blaze brought that up. And Laura and I started this interview, if you will, really asking Blaze to be brutally honest about their experience with integrated treatment, because we knew it wasn't all perfect, as much as we'd like to think so. And so this wasn't the only time that Blaze was kind of honest about the kind of the emotional complexity of it. But I think it was one that was important, certainly for me to hear.
Yeah, I think, again, speaking to sometimes why, you know, clients respond the way they respond, I think thinking back on working with Blaze for such a long time and working on so many things, you know, the eating disorder was always a major component. But, you know, working with somebody from the time they're 15 into their early 20s, I mean, we went through, you know, so many aspects of growing and relationships and identity. And there was, you know, trauma work, obviously. And such an important component of that was, you know, that they felt safe, that whatever it was that was happening, that they could bring it into the room. And I also think that they talk about that it wasn't uncommon for them at times when they were struggling to push a little bit us away, because at times that safety and that care didn't feel good because it went against what messages they maybe were getting at home or the trauma narratives they had. And the consistency that we provided, they didn't want. And there were many times that we had conversation around that. And again, we'll kind of talk a little bit about that in some of the other slides where we would kind of call it out and say, I think you're pushing us away. And, you know, that's important for us to kind of say in this moment and kind of hold up for you. And we'll keep talking to that, but I want to make sure we get through our slides.
Natalie, and I don't know if you can speak to this too, but Blaze, I remember some of those moments of holding your feet to the fire, in that, you know, the small moments of little things, like you would come in and like, what do you think about this? And I'd be like, you know, well, what would Natalie say? Or you need to talk to her. But in those bigger moments where it was, hey, you need more, you need a higher level of care, and you know, those moments happened individually with both of us, but only after a lot of conversations between the two of us, and a lot of conversations hopefully you remember having with us saying, hey, we're getting there's a point here that we're going to have to respond, and when that moment happened, we did, but those were really hard boundaries to hold.
Yeah.
And that was something Natalie and I both had to like support each other in, because we wanted you to be okay, and yet at the same time we knew how hard that was for you to ask you to do that and to go into that.
Yeah, I think, sorry, coughed a little bit. I think some of it too, you know, what was hard for me was like, you know, at times I felt like my team, like you guys, and then a few other people along the way, were the only people who cared, you know? So like when those hard decisions had to be made, I'm kind of just like, like, why would they do that to me? You know? And like, I genuinely, I do remember a lot of conversations. I still feel like there were a couple.
There's a couple of things that here that I kind of wanted to kind of pop in on. The one that was, I think, a really important point that Laura actually made is the kind of importance of integrative care, not just for the treatment of the client or the patient, but also for the clinicians. We are having to make some really, really hard decisions and have some really, really hard conversations with our clients, especially, well, that's not true for me, especially in the field of eating disorders. I know as mental health professionals, those conversations span all of the different experiences and things that are landing in your offices. But the relationships that we build through integrative care do help the clinicians to get through those hard moments, to try to make the best decisions for their patients, and to be supports to one another through that process. So I think that was something too that, again, I hadn't really thought too much about when preparing my mind for this talk tonight, but certainly came out in this conversation that we had with Blaze. And the next clip, I think, is important. What got cut here was actually Blaze saying that they felt like that sometimes they weren't allowed to fall down and pick themselves back up under our outpatient care. And that oftentimes, and you know, that there were a few occasions where we firmly recommended a step up to a higher level of care because of what we were seeing clinically and our concerns in that. And so the next clip kind of follows that. So I don't know, Laura, if you wanted to say anything else, but.
Oh, I think that's perfect. And yeah, I think this was a really important moment for us to hear. And And again, I think speaks to the importance of clinicians being open to hearing hard things and remembering that, you know, there is no easy answer, or it's an always this. You know, this is not easy to make these decisions that we sometimes have to make. And again, why it's so helpful and I think necessary to have a team helping make these decisions. And you'll hear Natalie and I own, you know, definitely not perfect, which I not a problem in acknowledging.
It was hard.
That's a really good point too that you brought up too, though, is that when you said there were a few times where you still think that maybe you didn't need to step up, that I think is important, that actually Laura and I talk about when we present, is the fact that like we don't know
Right.
all the time, right?
Yeah.
We're doing our best, and I think that isn't something that I'd actually even really thought too much about in terms of this presentation, but I think that's such an important thing for clinicians to know, is that we might think we know what's best, but we're just, you know, we make mistakes for sure, and sometimes they're big enough that it means stepping someone up who might not have benefited from a step up.
Right.
You know, and hopefully we're not doing harm, and of course it's not with anything other than best intentions based on what we, you know, see clinically, but that is very much a reality, is that clinicians do the very best that they can, and it also kind of speaks and make mistakes, and it also speaks to how important that collaborative piece is. And the fact, and I've said this before to other clients, like we talk about the treatment team, and I think the client or patient is actually one of the most important player on the team.
Yeah.
Yes, right?
Definitely.
And I think that can get lost in treatment amongst providers, even if they are working in an integrative way, forgetting that the client is the most important team member, and their contribution and collaboration is so important. And of course, we have to consider the fact that the eating disorders on the team too, and they're not our star player, but I think that just brings up, that's totally an aside, but I'm glad you mentioned that, Blaze. I'm glad you said that.
Well, and I'm so grateful too, because I think step-ups and higher level care are not always the answer, right? And when somebody is struggling, it's not always about, okay, I gotta move them up. And I think the clinician I am now, you know, would be very different to respond to you than the clinician maybe I was then as well. Because I was younger and still learning and growing, and what I felt capable of supporting probably looks very different now. And I would imagine for Natalie as well. But I also think that, you know, we aren't always right, and still doing the best we can. And I think, you know, it's.
I think after we did this talk, we enjoyed some things, and we cut out some of the video where we let Blaze roast us a bit, which was very enjoyable. But one of the things that I think Natalie and I talked about separately as we were coming back and rewatching some of the clips that we were going to use is how grateful we were, obviously, to be able to have this conversation with Blaze, but how I think good it felt, I'll speak for me, to know that this was a person who felt maybe we did make some mistakes, and yet the relationship we developed and the care they felt is what even now allows them to see and recognize we were doing our best and working in their best interest. And, you know, they're doing really well in their life. Their life is not perfect like anybody's, but they're doing really well. And this is somebody who had to really be resilient and work through so many things, and they've done it, and they're building an incredible and beautiful life for themselves, and not surprisingly wanting to work in mental health, which is amazing. So with that said, we want to make sure we leave our time for questions and answers. We are going to offer the full conversation with Blaze to be put up with tonight's talk. So if you are interested, you're welcome to watch it. They had some incredible things to say that we obviously couldn't fit in. But with that, I'm gonna say, let's hear some questions and answers. And Julie, if it's easier, we can kind of just go back into a different screen. I will put up resources and also share some others as well.
Sounds
Really.
great. Thank you both so much for your great presentation. This was really such a special treat for us, and all of the work that you put into this, and that interview with Blaze was really, really fantastic. So what I want to do right now is just sort of invite our audience members to kind of like go back to some of maybe the questions that you entered into the chat from earlier. We've got some time for some questions and answers, and please, this is the time to really kind of get that out there for more discussion. That's why we start our Q&A around 7:40.
So, do you just want us to kind of go through and
Yeah, I think what would be really helpful. Oh, that's great. Why aren't there medical professionals checking? Ooh. They go so quick.
they do. So one that a couple that I saw that I can kind of quickly answer that were a little bit earlier on, and then I kind of had to pay attention to my presentation, was in regards to kind of outreach and reaching athletics and schools and things like that. And the questions were kind of posed in terms of like, is any outreach being done? I think that's so important. And I think that's exactly, you know, we're not the area, but one of the things that really needs to be looked at is school curriculum, healthcare or like health ed curriculum. So I know myself in my practice, we work really hard at getting into schools. I have 8 talks, which is amazing, but my goodness, this month at a local middle school talking about eating disorders and body image. And so definitely, you know, I think it's for me personally, I think it's really important that providers do that outreach. And I think that that also needs to be done in urban areas as well as the suburbs where my practice is. So I think it is being done. There are some really incredible organizations. The Body Empowerment Project is out there. They do some incredible work in this area. So it's being done. It needs to be done more, but I can, like I said, I can kind of speak for myself, and we are always kind of knocking on the doors of different athletic departments and different schools, as well as trying to get in front of counselors or anybody who's kind of in charge of those types of things to address some of those issues earlier on to kind of work on prevention.
Yeah. And again, speaking to athletics in particular, you know, again, we have to break out of old stereotypes of what we think an eating disorder is and who it affects. You know, the reality is that so many people who are struggling are missed. And a lot of times that is people who identify as male, that's people in our BIPOC community, you know, individuals in larger bodies. We have to stop thinking that there's a way a person looks or a certain identity that a person has, and they're the only ones that have eating disorders, because like we're saying, there are certain sports or certain things that kind of require an awareness around body and weight. And there's a very fine line that has to be walked and managed. And so it's an important thing that we're having conversations with people who do participate, coaches, things like that. And likewise, we're always connecting with counselors, school districts, things like that, and happy to come and talk anywhere. One of the best things I think, at least parts of the job that I love, is in fact is being able to talk and share and get more message out there for other people to help spread.
There was a question, another kind of relatively quick one, I think, regarding some eating disorder behaviors and kind of, do we consider them self-harm behaviors? Oftentimes, yes, Laura, I think you can speak to that much better than me, but I know in my experience, we definitely sometimes frame those and oftentimes consider them a form of self-harm, not across the board, but for for some individuals.
Yeah, absolutely. I mean, I think again, you have to really challenge the normalness, the normality of what people do. But when we're really slowing it down, a lot of the times it's what's the intention behind, even when it is just to lose weight. Again, it's this idea of like, would you want this to happen to a toddler? Would you want this to be your friend going through this, and helping them kind of see a third person? And if they think it's not okay for someone else, why is it okay for them? But yes, it is definitely something that we have to look at in that same way. And I think this is also where we want to hold up the idea that coping strategies are coping strategies, and they oftentimes do a whack-a-mole. So if somebody is struggling with self-harm, and that starts to be something they're working on, or for some reason gets taken away, we might see it pop up, and we might see an increase in purging behavior, restricting behavior. So oftentimes it's less about what they're doing, but what again is causing, what are the underlying factors that are leading to these needs and ways of coping. So a lot of the times we don't want to get caught always on the surface of what's happening. We want to kind of go underneath of it. But yes, it is very important to address it and acknowledge it like that.
Yeah. I just saw one question about how intuitive eating falls under disordered eating. I'm sorry, it doesn't. If that slide was it all confusing? It was kind of saying that it's almost kind of the opposite of disordered eating. Hannah, I'm not sure if I'm kind of answering that question that you had, but rather that spectrum being kind of intuitive eating being the goal for most people, not always achievable, to be honest, in some ways for some people, but the goal, and then an eating disorder being kind of the other end of that spectrum or pendulum. However, I will say that intuitive eating has been in many ways kind of hijacked by diet culture. So sometimes, if it's being done and practiced and promoted in the way that it was intended, then it is, like I said, it's kind of the opposite of disordered eating or eating disorders. However, like I said, it's kind of turned into or been hijacked and manipulated to be somewhat of a diet as well, when not used how it's indicated.
Natalie, here's one for you. Great question about a mom with middle school kids. What is the best way to identify good versus junk foods without creating guilt when we do serve them?
It's such a good question, such a hard task. And let me just say, I can, as a relatively new mom, I can very much appreciate that question now, and that struggle now more than I could have, 3-4 years ago. So the way that I try to kind of frame food is that it's all good. It's good in different ways. Because there is no doubt that some foods provide certain nutrients or certain things that are very different than other foods, but they are all good and they all can serve a purpose. So for instance, that's easy to do when we're talking about our traditionally healthy foods, right? The vitamins, the nutrients, the protein, build big, strong muscles, etc. I think it's harder for some of us to kind of wrap our heads around how a Twinkie could be considered good. And it can, because it provides a really delicious taste. It provides energy. There are calories, it provides energy. It's convenient. And for so many people, affordability and convenience and being shelf stable is incredibly important and is a huge benefit. So I like to kind of frame foods as all beneficial, all healthy, if you will, and just really trying to, educate and explore the different ways that they are that, and emphasize that we need all of them, right? That nothing is healthy if it's the only thing we're doing, right? And so we do need all of these foods. And so, like I said, that has kind of been how I've encouraged parents to kind of view food themselves and then try to pass that information down to their children, because otherwise, labeling it good and bad, or, there was a time where I said fun foods, but that's still labels it, and it still has a connotation, and it still has some meaning to it that it probably doesn't need. So there's really, that being said, we do our best. We do our best. And I think just the fact that you are interested in knowing that information is probably enough, you know, and probably already is so protective of that guilt that you're talking about, that a child might feel around certain foods. So I don't know that we have a perfect way of doing this. And it's really then easy for us as parents or us as caregivers or friends or family to feel our own guilt if we don't do it the right way. And so I also think we kind of have to let go of that and do our best.
Going back to, you know, no perfect therapist or dietitian, there's no perfect parent. What I will say, and as the clinician who does not and cannot break down this is why this and this does this, but I love when they can do that to the client, so that then suddenly they're like, oh, I can get nutrition from that. What I will often say is the importance of food is amoral. We put value on food. We put good, bad, healthy, unhealthy. And again, going back to what we were talking about before, there's reasons for that. And so we really need to get away from, you know, labeling it like that, looking at it like that. Food is fuel. Our bodies need it. We don't question why we have to breathe. We don't question when we need to go to the bathroom. These are things we need. Food is something we need. And so we stop and really start to question, why am I challenging this? Why am I asking this? And then another way that I talk to my clients about this is when they're struggling with something, they're like, well, I feel bad I ate this. I said, okay, well, that was, you know, one meal in 1 day, 1 day in 1 week, 1 week in 1 month, 1 month in 1 year. Like we're talking about a balance, right? So like this one thing doesn't even touch, right? It's the bigger picture. It's not one meal, and getting away from that kind of judgment. And also reminding us to think about maybe what are some of our own biases? How do we look and think about food? How do we look and think about our bodies? Because we have a great impact, not only on if we are, we have children, but everyone around us. I know we can all relate to what it's like to be around people who are, you know, connecting over body shaming, or connecting over, oh, I've been so bad this week, or, oh, I can't do this. Like all of that is something we need to stop and pay attention to if we want to challenge these norms, if we want to start breaking this pattern that exists in our society to feel bad about ourselves, and that our worth matters more in what we look like than in the whole person that we are.
Laura and Natalie, I hate to cut this off because it's really just such a fascinating topic and so important. And clearly, I think this is like maybe the highest number of attendees we've ever had at one of our Epic events, but I have to check with Wendy and Sarah. So quick question for you both. Would you possibly be interested in having like a post, kind of like a Q&A recorded with just me, and then maybe we could post that to our Epic site?
Yeah.
We can talk about that later. No pressure in front of like 275 people. All right, I'm going to share my screen right now, and this is the post-test slide. So thank you both so much.